Friends, now we'll begin with salivary glands. So we can classify salivary glands in minor salivary glands and major salivary glands. We have approximately 450 which are smaller in size as minor salivary glands. Amongst major salivary glands, we have got parotid glands which are bilateral, submandibular glands which are bilateral on both sides of mandible region, and sublingual glands which are present in the floor of the mouth. So now we'll see minor salivary glands. The mucosa of oral cavity contains approximately 450 minor salivary glands. So they are contained in the mucosa of the oral cavity. They are lining the lips, cheeks, palate, floor of the mouth, retromolar area, oropharynx, larynx, trachea and sinuses. So you may be asked a question, in which of the following regions you may not find minor salivary glands. So they may add additional one where you cannot find minor salivary glands. So please go through the sites of minor salivary glands carefully. Overall they contribute to 10% of total salivary volume. They have a histological structure that is similar to that of mucus secreting major salivary glands. Now we'll see what are the disorders. Most commonly, the cysts are formed from minor salivary glands. They are generally extravasation cysts which are common and result from trauma to overlying mucosa. So you may be asked, the cysts of minor salivary glands are extravasation cysts or retention cysts. So these are extravasation cysts. They are located in the lower lip. They are painless and translucent. Treatment, they resolve spontaneously while most require formal excision that includes the overlying mucosa and underlying minor salivary gland. Recurrence is rare. Now we see tumors arising from minor salivary glands. Tumors of minor salivary glands are histologically similar to those of major salivary glands. Up to 90% of minor salivary gland tumors are malignant. So this sentence should be noted. So most of them, when they occur, they are malignant. Tumors of minor salivary gland origin anywhere in the upper aerodigestive tract. Common sites are upper lip, palate and retromolar region. These tumors arise in submucosal seromucous glands that are found throughout the upper aerodigestive tract. So benign ones, they present as painless, firm, slow-going swellings. When they involve upper lip, the treatment involves excision including overlying mucosa with primary closure. But when they involve in the palate, when they are of less than 1 cm size, the excisional biopsy with healing the defect by secondary intention is followed. But when they are of more than 1 cm size, incisional biopsy is followed by formal excision. So you have to initially get incisional biopsy, you have to document that it is benign, and then you have to excise it formally. When malignancy is detected, they are firm in consistency along with overlying mucosa may have a varied discoloration from pink to blue or black. The tumors may become necrotic with ulceration as a late presentation. Wide excision with partial or total maxillectomy followed by prosthetic obturation or immediate reconstruction of the defect with microvascular flap is needed. So there will be large defect in the maxilla or surrounding area that has to be repaired with microvascular flap. Various microvascular flaps include radial forearm flap, fibular flap, rectus abdominis flap, latissimus dorsi flap and the vascularized iliac crest graft. You can be asked question of how to manage benign tumors and how to manage malignant tumors. So you may be given a scenario where the tumor size is less than 1 cm is best treated by following options, and the tumor size is more than 1 cm is best treated by, they will give various options. Or when they will give option as malignant tumor, they may add various options of treatment of minor salivary glands which are benign or malignant along with some pedicle like graft. So you have to choose that whenever you encounter malignancy, you have to reconstruct the defect with vascularized free pedicle grafts. Now we'll see sublingual glands. They are generally paired. They are located in the anterior part of the mouth between the mucous membrane and the mylohyoid muscle and the body of mandible. Numerous ducts open directly into mouth, or indirectly we have ducts that open into submandibular duct. These are ducts of Rivinus or Bartholin's duct. Blood supply is of lingual artery and submental branch of facial artery. Lymphatic drainage is through the submandibular nodes. What are the various disorders of sublingual glands? Most commonly the cysts. These are minor mucus retention cysts that develop in the floor of the mouth, either from an obstructed minor salivary gland or from the sublingual salivary gland. The cysts that arise from sublingual glands are called as ranula. It will produce a characteristic translucent swelling that will take an appearance of a frog's belly. Hence it is named as ranula. So you know the frog is called Rana tigrina. A ranula can resolve spontaneously, but many also require formal surgical excision of the cyst and affected sublingual gland. Incident drainage usually will occur in recurrence. So best management is by radical or formal excision of the cyst and affected sublingual gland. So you may be asked question, treatment for ranula is surgical excision and affected sublingual glands, or they may give option as incident drainage also. So it is surgical excision along with excision of affected sublingual gland that will prevent the recurrence. Now we will see plunging ranula. It is a rare form of mucus retention cyst that can arise from both sublingual and submandibular salivary glands. So friends, you should note a difference. It is mucus retention cyst. It is not extravasation cyst. So you should note this difference, because you may be asked what are the following types, or plunging ranula is retention cyst or extravasation cyst. So you may be confused. So you should remember that it is mucus retention cyst. The mucus will collect within the cyst, which will perforate through mylohyoid muscle diaphragm to enter the neck. So mylohyoid muscle, which is located at the floor of the mouth, it will go through mylohyoid muscle and it will cause swelling in the submandibular region. It will be dumbbell shaped swelling that is soft, fluctuant and painless in submandibular or submental region of the neck. Diagnosis is made on ultrasound or MRI. Treatment is generally excision, which is performed via cervical approach, removing the cyst and both the submandibular gland and sublingual glands. So submandibular gland along with sublingual glands are excised. Smaller plunging ranulas can be treated successfully by transferal sublingual gland excision with or without marsupialization. So how do you manage sublingual ranulas or submandibular ranulas is made clear from this. Friends, now we'll see tumors arising from sublingual glands. So tumors involving sublingual gland are extremely rare, but they are generally malignant when detected. They present as a hard or firm painless swelling in the floor of the mouth. Treatment requires wide excision involving the overlying mucosa and simultaneous neck dissection. Immediate reconstruction of the intraoral defect is recommended using the free flaps. Generally, radial artery free flap is used. Now we'll see various disorders of submandibular gland. So these are generally paired. They lie below mandible on each side. Generally, they are located in submandibular triangle. They will consist, so these glands will consist of large superficial and smaller deep lobe that are continuous around posterior border of mylohyoid muscle. So you should mark this statement. So mylohyoid muscle will form division between superficial and deep lobe. So you may be asked question. Submandibular glands have capsule which is formed by superficial layer of deep cervical fascia. It has got a duct which is single called as Wharton's duct. It will drain into anterior floor of the mouth at sublingual papilla. Important anatomical relationships of submandibular gland include lingual nerve, hypoglossal nerve, anterior facial vein, facial artery and marginal mandibular branch of facial nerve. So these 5 structures should be remembered carefully because they can be injured during excision of submandibular gland, or these structures are likely, or these nerves are likely to be injured while removing sublingual gland. So lingual nerve, hypoglossal nerve, and marginal mandibular branch of facial nerve. Now we'll see various disorders of submandibular gland. So we have got an interesting disorder of Staphney bone cyst. It is ectopic aberrant submandibular gland. So it will present as asymptomatic, clearly demarcated radiolucency at the angle of mandible below inferior dental neurovascular bundle. So you may be given a clinical scenario where described a translucent lesion seen at the angle of mandible. You may be given various options. Most likely it is Staphney bone cyst, or they will give various options like mucus retention cyst or other swellings. So you have to choose this translucent swelling seen at the angle of mandible as Staphney bone cyst. So it is formed by invagination into the bone on the lingual aspect of the mandible of an ectopic lobe of submandibular gland. So friends, this bone cyst is not the cyst arising in the bone, but it is the lingual aspect. But friends, this cyst is not arising from the bone, but it is formed by invagination into the bone on lingual aspect by ectopic lobe of submandibular gland. So it is submandibular gland lobe which is invaginating in the bone, forming a cyst-like appearance on X-ray. Generally, no treatment is required. So treatment required for Staphney bone cyst is, they will say excision and all other things, and no treatment is required. You may be confused, how come cyst has got no treatment? So this is the point that you should mark it carefully. Now we'll see various inflammatory disorders of submandibular gland. Inflammation of the submandibular gland is termed as sialoadenitis. We have got types as acute and chronic. Generally, the acute is caused by viral. The paramyxovirus or mumps is a viral illness of salivary glands that usually produces parotitis. But the same when affects submandibular gland, it can cause acute submandibular sialoadenitis. The submandibular glands are occasionally involved, causing painful, tender, swollen glands. So next we have got the bacterial sialoadenitis. So it is more common than viral and can occur secondary to obstruction. The gland frequently becomes chronically inflamed and they may require formal excision. We can have chronic inflammation of submandibular gland named as chronic submandibular sialoadenitis. Next we will see what are lesions that will affect submandibular gland, such as affecting the duct by obstruction of it or by recurrent trauma to the duct. So most common cause of obstruction is within the submandibular gland, which is by stone formation. It is called as sialolithiasis. The stones are formed within the gland or its associated duct system. 80% of all salivary stones occur in the submandibular gland because their secretions are highly viscous. So this is a very important statement because they may ask question, most commonly salivary gland stones are seen in which ducts? Submandibular, sublingual or parotid? It is submandibular gland. Why? Because they are highly viscous. And one more reason you can add to is that the submandibular glands are located at the lower level than their opening. So the drainage is against gravity. So there may be tendency of retention of secretions leading to sialolithiasis. 80% of submandibular stones are radio-opaque and they can be identified on plain radiography. So you have to take special X-ray of the floor of the mouth for that. The painful swelling that will occur rapidly and often resolve spontaneously over 1 to 2 hours after the meal is completed. So you can see classically the swelling appears within 1 to 2 hours after the meal. The swelling will enlarge rapidly and within next 1 to 2 hours of the meal is completed, the swelling will resolve on its own. If the stone is lying within the submandibular duct in the floor of the mouth, anterior to the point at which the duct will cross the lingual nerve, the stone is removed by incising longitudinally over the duct. So you should go through these statements very carefully. How do you manage these stones? So it has got relation with the lingual nerve. So when the stones are anterior to the crossing of lingual nerve to the duct, then the incision is given on the duct to remove the stone. After you remove the stone, the duct is kept open, it is not closed, because if you close the duct, it may form stenosis and it may form the recurrence of stones. So the location is where the duct crosses lingual nerve, which is generally at the second molar region. So this is very important. You may be given a question stating that where the duct or where the stone is anterior to the crossing of lingual nerve. So how do you treat these stones? They may be given various options. So, or you may be given a vice versa, intraoral drainage of submandibular stones is done in which situations? Next, we have got the situation where the stone is proximal to the lingual nerve, that is at the hilum of the gland. So it is located very much back, very much near to the gland. So stone is retrieved via an intraoral approach. It should be condemned. So in this situation, intraoral approach is not advocated because there will be high risk to damage to the lingual nerve during exploration in the posterior lingual gutter. So you should note these two situations very carefully. So in these situations, the treatment is by simultaneous submandibular gland excision along with removal of the stone and ligation of the submandibular duct under direct vision. Here the treatment is done through externally. Next we go to the indications of submandibular gland excision. So it is done for sialadenitis and for salivary tumors. So excision of submandibular gland involves distinct phases. So as you go deep, you encounter various structures. So these are to be tackled at that specific step. So first will involve incision and exposure of the gland. So how the incision is located. So you know that marginal mandibular branch of facial nerve runs on the lower angle of the mandible. So incision should be marked at least 3 to 4 centimeters below the lower border of mandible to avoid damage to the marginal mandibular branch of the facial nerve. So you may be asked question on this sentence. So which of the following nerves are likely to be damaged during incision for excision of submandibular gland? So you should note that they have specifically added word incision. When you take incision, these nerves are likely to damage. But if you go deep down, there are other nerves which can be damaged. So incision should no more be than 6 cm. You should restrict your length of incision to 6 cm. Next we have got stages of gland mobilization. In inflammatory conditions, the submandibular gland is excised by intracapsular dissection. So this is very important statement. Whenever there is inflammation, the gland is excised by intracapsular dissection. For tumors of the submandibular gland, extracapsular dissection by suprahyoid neck dissection is performed. So when you encounter malignancy, extracapsular dissection is done. The superficial lobe of submandibular gland is first mobilized by retracting superiorly. Then you divide the facial artery to facilitate further mobilization. So you may be asked which of the following arteries is divided during removal of submandibular gland. It is facial artery. Next you dissect deep lobe and identify lingual nerve. Next we go deep and you prevent damage to hypoglossal nerve. So all these nerves are very close to submandibular gland and they should be carefully preserved. So the 3 cranial nerves which are at risk during removal of submandibular gland are marginal mandibular branch of facial nerve, lingual nerve and hypoglossal nerve. So friends, now we come to tumors. So these are uncommon. They present as a slow growing painless swelling within the submandibular triangle. 50% of them are benign. The clinical features of malignant salivary tumors, they will include facial nerve weakness, rapid enlargement of the swelling, induration with or without ulceration of the overlying skin. So when the tumors increase, they will fungate and they will cause ulceration. They may cause metastasis to cervical lymph nodes causing swellings. How do you investigate? Computerized tomography and MRI are the investigation of choice. Friends, here open surgical biopsy is contraindicated as they may seed tumors into surrounding tissues. So FNAC, that is fine needle aspiration cytology, is a safe alternative to open biopsy. So you have to do FNAC So you may be asked question, which of the following is done for diagnosis of salivary gland tumors arising from submandibular gland? So you should open biopsy is not done. So you may be asked question on various types of diagnosing method for submandibular tumors. So how do you manage these tumors? As with all salivary gland tumors, surgical excision with the cuff of normal tissue is the goal. But when the tumors are small and they are entirely encased within the submandibular gland parenchyma, straightforward intracapsular submandibular gland excision is appropriate. So when you got smaller tumors, you can do intracapsular excision. So you should be maintaining a cuff of normal gland parenchyma along with the tumor. Benign tumors that are large and project beyond the submandibular gland are best served by suprahyoid neck dissection, preserving marginal mandibular branch of facial nerve, lingual nerve and hypoglossal nerve. So when you have got larger tumors, they will require neck dissection. In cases of malignancy, modified neck dissection or radical dissection is appropriate with the sacrifice of lingual, hypoglossal nerves if the tumor is adherent to deep bed of the gland. So whenever these nerves are involved, they can be sacrificed if you encounter malignant nature of the tumor. So friends, in this lecture we saw minor salivary glands and submandibular and sublingual salivary glands. We saw various their benign diseases and malignant diseases. We saw a very important point, that is drainage of submandibular salivary. We saw a very important point of removal of submandibular salivary stones. Thank you.